Okay, so the first thing we can start with culture. So as we know, similar to what has been happening in the field of social work in general, culture is now racism, all those things are becoming more the focus of different things. So the DSM-5 TR is not excluded from that. So some of the terms that they were using, they now have changed them. So instead of saying race, they say racialized. They use the term ethno-racial to kind of capture some of those other categories. Instead of saying terms like minority and non-white, they try to avoid those things. The term majority, they're going to be avoiding any of those terms in the DSM-5 TR. The emerging term, Latinx, which you should also already be familiar with, is something that they wanted to make sure they promote for gender inclusiveness. Terms like Caucasian is not being used anymore. And that's prevalence data on specific ethno-racial groups were included when existing. Yeah, so they try to include more research on different racial groups. That was basically what that handout went over, but I just wanted you to know that those things were on there. So we get rid of that. Okay, here is kind of another handout that just gives you some of the things that are changing. So the addition, so they revised criteria for 70 disorders, but when it says revised criteria, some of those revisions is what we just talked about, right? Some of the terms that were used, they look at that. And then we're going to look at some other things. They also have a new disorder. So out of everything we talk about, I would say the new disorder would be the most important, just in case they try to put the prolonged grief disorder on the exam. You just want to have that information. So the prolonged grief disorder is here. It gives you a little bit of criteria. And then in your spare time, you may just want to pull up the actual DSM-5 TR criteria, the list of criteria, so you can get a more picture about what they're really talking about. So when we talk about prolonged grief disorder, and this is good too, because a lot of times we really try to figure out, is it grief or is it depression, right? What's the difference? When does it become clinical depression? So this addition of this disorder is actually pretty major, because in the past, we really have not viewed grief as a mental health illness unless it turned into something else. So this is actually allowing us to have these symptoms that are grief related, right? The DSM-5 really didn't give a lot of room for that. We pretty much had to categorize the person, even if they were experiencing grief, we had to categorize them as being major depressive and all of those other things. So this is really looking at grief, distressing symptoms of grief that are for at least 12 months following the loss of the person. And then it just gives you some symptoms, right? Impairment in daily functioning. So what I want you to do is put that in your mind, write it down. Impairment in daily functioning. For anyone to have a disorder, they have to have some type of impairment. So if it ever asks you anything about, what characterizes a mental health disorder, what is the primary feature of a mental health disorder, is impairment across the board, right? And then they also had another category in terms of the another category, unspecified mood disorder. So that's just something to kind of refresh your memory on. And then they had some other things, other changes with some substance use disorders, suicidal behavior, changes to the autism criterion. So in your spare time, just kind of review these things. I know it is a lot of material. It is a lot of material, but really what I want you to read it for is just so that you know. right? So that you're like, okay, I've heard of that before. And if you're in the space, if you're a therapist, then you probably already know these things because you're implementing them, right? So this is really for people that do not have a lot of exposure to clinical information. All right, so let's go ahead and get into our slides for tonight. What we're going to do tonight is an overview. You are not going to come out after 9:30 Eastern Standard Time with a committed memory of the disorders, okay? This is going to take you some time to understand, but what I want you to know is that if you're like me and you're not a clinician, you do not have to be a clinician to pass the exams, especially on the master's level. On the clinical level, it would probably really help if you were a clinician and you've been getting kind of your hours or depending on your state. But even at the clinical level, it really isn't testing you about how well you're a clinician, right? It's not testing you about, well, what do your clients say? And are you good at engaging them? It's not really asking those types of things, right? It's really wanting to know some root things. So we're going to talk about that. Before we get into going over the disorders, I just wanted to give you a refresher. So when you think about disorders, when we are assessing for an emotional or a mental health disorder, we need to rule out medical first. And our last class that we did, we had some questions about that, right? So if we are assessing for a mental health disorder and physical symptoms are present, then we want to just check in with the client to see, have they gone to their doctor about these symptoms? So for example, if I'm saying I have depression, but I'm having trouble sleeping, I'm very fatigued, I have a loss of appetite, I want to make sure that my client has gone to see the doctor about those particular symptoms before I proceed to give them a diagnosis. Why? Because part of the DSM is that we eliminate an organic cause to the mental health disorder, right? Because if there's an organic cause, then it's not a mental health disorder, right? And so we want to make sure that happens before we give any diagnosis. Another reminder, because we are talking about, we're going to talk about depression, is remember when we conduct the suicide assessment. I just wanted to remind you that when we have depressive symptoms in combination with some type of loss that does not have to be associated with death, right? It could be a loss of a person, but it also could be a loss of a job, a loss of a relationship, a loss of purpose could also be a loss. So if we're seeing that event, that loss event, and then we're also seeing depressive symptoms, then we want to make sure that if it says conduct a suicide assessment, then that's probably the answer if we have both of those things happening. And we're going to go over in depth what the depressive symptoms are. Okay, I love this slide. Here are my hot topics. Hot topics. Does this mean you can only study these things? No. But if diagnosis and medication overwhelms you, you can start with these disorders and medication and just understanding some of these terms, right? A lot of diagnosis and medication is definition memorization, right? So it's either you know the terms or you don't, kind of thing. So the more exposure you get to different terms, the better. On my exam, I think it was my master's exam, I had a therapy approach that I had never heard of on my exam. And I told myself that I was going to look it up after the exam, but of course I had absolutely no idea. what it was, but I just remember looking at it and saying, what in the world? I have never heard of this. And that may happen to you as well. So some common disorders: schizophrenia, right? Major depressive disorder, bipolar 1 and 2, general anxiety disorder. That's what GAD means. General anxiety disorder, social anxiety, schizoid personality disorder. That's what the PD means. And you'll see a whole list of the personality disorders. Still personality, basically all of them. Adjustment disorder, enuresis, encopresis, ADHD, ODD, conduct, OCD. We're going to talk about all of those. And even our sexual disorders. Just, you don't really need to know everything about them, but just knowing that there are sexual disorders and what they are would be good for you to know, because those kind of get skipped over. And also sleep-wake disorders. Now, those disorders, I don't have any slides on sleep-wake disorders, but the reason I gave you a list is because when people are saying to me common things, then I'm adding them to the list. So someone told me sleep-wake was on there, and I was like, oh, really? So just to let you know. And again, it doesn't mean that any of these things are going to be on your exam. And it also doesn't mean that you're going to get a lot of diagnosis and medication. And I'm going to share with you some of my tips for studying in a second. Here are some common medications. Again, the brand name and the generic is important because lorazepam is a generic brand. Yeah, Maria says she only got 2 questions. Yeah. So I'm about to tell you some tips on it because it's a lot of information to just get 2 questions, right? Paradoxical effect. This, again, somebody was like, what is that? Never heard of it. It basically refers to how ADHD, you would not think that you would give a stimulant to someone with ADHD. They're already hyper, right? But actually giving a stimulant to someone who is hyperactive actually has the opposite effect on them, right? So it's not going to make them more hyperactive. It's actually going to do the opposite. So that's what paradoxical effect means. Like, oh, wow, that's crazy. It's like a paradox. And then substance use terms, because substance use is on the exam and has been kind of told, I've been told that it seems to creep on there a little more and more. So you want to make sure that you have a just general understanding of some substance use terms, okay? What are my pieces of advice? Here we go. Highlight all of the symptoms present in the question. It's going to be very, 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 very obvious that it's a diagnosis question because of the fact that there are disorders in the answer. So you'll know right away, okay, I need to diagnose. So you want to make sure that you highlight. Now, when I say highlight, you can use the tool in the software for the exam to highlight, or what I'm just simply saying is pay attention to all of the symptoms. Don't just focus on one symptom. If you were to focus on irritability, you would be in trouble because there's like 15 disorders that irritability is a symptom. So you really want to highlight all of the symptoms, and you want to make sure that you know the main features of the disorder, right? So again, depression has a whole list of different symptoms, but there are some symptoms that you must have in order to be diagnosed that way. And a lot of the disorders have that, right? They'll have a list, you have to have at least 5, but out of the 5, you have to have these 2 things, right? So those would be your main features of the disorder. Time frame is key, age of onset. Those are all things that are really, really important to understand, okay? For the master's exam, symptom recognition is key. For the clinical exam, differential diagnosis is key. So we're not going to dive deep into differential diagnosis, but just know that there are times where you're assessing for depression, but there could be some differential diagnosis, meaning that there's some overlap, right? So before you say, hey, it's definitely depression, you want to rule out some of the other differential diagnosis of what it could be, right? So that's just what that means. The other thing, to the point of Maria, getting 2 questions after studying all this stuff is very, very discouraging. However, even though there are other scenario questions, sometimes you'll need to know about depression to answer the question. So is there a lot of disorder questions where you're diagnosing? No, not even on the clinical. I would think the clinical would be just diagnosing, but it's not, right? You're still going to get all of the scenario-based questions. So when you're studying diagnosis and medication, I really don't want you to study it for a month. That's too long. Okay. I would really look at this as maybe dedicating a week of study to this, but I would not really go past that. And you want to make sure your week of study is thorough, but you also want to make sure that you're just studying the key features. Don't study the entire DSM-5. I remember when I was studying for both exams, I had the entire DSM-5 out and I was reading it, right? Now you can do that if that helps you, but it's really not necessary because you're not going to be needing that key of detail in order to answer the questions. Also, with diagnosis and medication, sometimes they do ask you information that was in the prevalence or those areas that no one really reads, right? We go straight to the criteria. So sometimes they will ask you questions that come before it. Don't worry. You probably don't know the answer, just guess. And it's okay. You'll be okay. They're not going to ask you too many questions from that standpoint, but they will ask you questions like, is bipolar more prevalent in men or women? And you're like, what? I don't know. So those types of things, you may or may not know, but don't freak out. So as we go through the disorders, one thing I want to remind you is that this is being recorded, and I do want you to review this recording multiple times. So as we're going through, you may have some questions, and I want you to ask your questions. But just keep in mind that if it's something that you need repeated, that you can always rewind it once you watch it back. We are going to go through the disorders, majority of them in categories. At the end, I do throw in some random disorders, but the first part is going to be in categories. And the reason I do that is because the reason that they categorize the disorders in the way that they did is because they're similar, right? And so when you have something that's similar, we can see what the differences are, and that's going to really help you understand why DMDD is DMDD and it's not something else, ODD, conduct. It's not those things, but it's actually DMDD, okay? All right, so it's a depressive disorder. So we're going to look at our time frame. Must be present for at least 12 months. So if you read the question and you're considering DMDD, sometimes it will tell you how long the symptoms were present, and sometimes it will not say, right? But if it does say, you want to really, really hone in on that. You also want to keep in mind the age of the child. DMDD is typically going to be in children, right? It happens between the ages of 6 to 18, so it's considered like a child disorder. So you want to keep that in mind as well, that if we're looking at an adult, then this may not really fit their symptoms, okay? What are the major criteria? So as we go through the slides, you'll see some teal or that bluish color. That's just me, I'm visual. And so I wanted to make sure that you knew that this was really, really, really important. The other words on the slide are also important, but more for context. So if you were to write on a note card, what is DMDD? You're going to write, must be present for 12 months, occurs between the ages of 6 to 18. And then you're going to go into what the symptoms are. The major symptom is severe persistent irritability. Okay, that's important, but it goes along with temper outbursts. So You want to see both of those things. Like I said, irritability is in a lot of disorders. So even if you don't see irritability, but you see temper outbursts, you'll know, okay, this is something that is unique to DMDD. And the temper outbursts are grossly out of proportion in intensity or duration and not consistent with the child's developmental age, right? So we're not talking about a 4-year-old having a tantrum. That's not what we're talking about. What we're saying is that the child is 11. You told the child you cannot have a cookie before dinner, and that child took a brick and threw it through the window. Okay, intense. Or they're having a temper outburst for hours, right? That would also, even though it's not as intense, maybe they're not breaking things, but they are having a temper outburst for a long duration. It's grossly out of proportion, right? It doesn't match why they're actually upset. It also must happen in at least 2 settings. This is very important as well. Has to be in 2 settings, at least 2 settings. For example, home and school. Right, so sometimes with ODD, oppositional defiant disorder, it can present at home and not at school. So this is different, right? It has to present in at least 2 settings. And then the other things are just giving you some examples of other types of behaviors, but those are the main behaviors for this disorder. So you're going to write severe persistent irritability, ages 6 through 18, must be present for at least 12 months, severe temper outbursts, grossly out of proportion, you can put that in there too, and occurs in at least 2 settings. That's it. That's all I want you to memorize. I don't need you to memorize really anything else. So you see how we took a whole criteria that probably had A, B, C, D, E, and we broke it down to about 5 things you need to know. So that's what I want you to do for every disorder so that you're not like going crazy. It's still a lot, but it reduces your memorization a little bit. Okay, now we're going to talk about depression. Now, depression is something that we're all very familiar with. We're all familiar with the symptoms. So we're good on the symptoms. But what I wanted to point out is that there is a major depressive episode and there is a major depressive disorder. So sometimes people get confused. Why is there an episode and a disorder? Are they the same thing? Why is it separate? So I'm going to give you this analogy. And those who have taken this class before, you remember the analogy, right? Major depressive episode is like an ingredient in a recipe. The reason why they have separated major depression into an episode is because when we think about the various mood disorders, major depressive episode can be combined with other ingredients and make a whole nother dish or dinner, right? So if major depression is mixed with manic, it's bipolar. If major depression is mixed with schizophrenia symptoms, then it's we're gonna figure it out. I think it's schizoid. Schizo something. Skit something. All right. So major depressive episode is an ingredient. When it is mixed with other things, we're going to get a totally different product. Okay. That's the only reason why it's separated out. So major depressive disorder just says, hey, I have a client that has had a major depressive episode, at least one, right? Again, if they're having other types of mood episodes, then they might not have major depressive disorder. They may have another disorder. So that's the only reason why it's separated out. Okay. So major depressive disorder is the only ingredient is major depressive episode. And a major depressive episode, this is the criteria that I want you to write down. you have to have at least 5 symptoms. You can list out all the symptoms. Some are on this page and then some are on the previous page, right? Sleep disturbance, fatigue, loss of energy, feeling of worthlessness, an inability to concentrate. They might have some thoughts of death, things like that, okay? So those are some of the symptoms. What are some others? Loss of pleasure, significant weight change, appetite disturbance, either more appetite or less appetite, right? Either weight gain or weight loss. Both could be a symptom. So it has to be at least 5 of those. And it has to be persistent within the same 2-week period. So major depressive episode is a 2-week period. At least 5 symptoms. But to be honest, you're not going to be counting how many symptoms is in the scenario. You're not. What you do want to understand is that it's a 2-week period. And this is what is categorized. At least one of the symptoms. So at least one of the 5 has to be either a diminished interest or pleasure, or a depressed mood. Diminished interest or diminished pleasure, meaning I used to find knitting really pleasurable to me, and I no longer find it pleasurable. And it's not just I changed my hobby, but I really am not interested in what I used to be interested in. I used to go out and I used to socialize. I don't do that anymore. Okay, those are examples. Depressed mood, extreme sadness, crying could be a depressed mood. So that has to be in the symptoms for MDE to be present. Okay, so we got major depressive disorder. The only ingredient we need for major depressive disorder is major depressive episode. That's it. There's nothing else going on. What you do need to know is that in children, depression presents as irritability. So they're really not sad necessarily. They're not like crying and being sad and lonely and things like that, but they're highly irritable. So you see that word, here it comes again. Okay, we're continuing on. Here's our next recipe. Persistent depressive disorder. This never meets the criteria for MDE. Why? Because we only need 2 symptoms, right? MDE needed 5 symptoms. PDD only needs 2 symptoms, and they're the same symptoms, okay? Same depressive symptoms. And they never meet the criteria for MDE. It's going to definitely mention the time frame, because the time frame is really what separates PDD from MDE, right? So it has to be a minimum of 2 years of depressed mood. Here we go again. You have to have depressed mood, okay? In combination with other depressive symptoms. 2 years in adults and 1 year in children and adolescents. So you see the difference. MDE, it can be a short period of time, 2 weeks, whereas PDD is extended. It's like long-term non-depression. It's depression, but it's not as severe. It's like a less severe, but like it won't go away. So what you would write down is never met the criteria for MDE, minimum of 2 years in adults, 1 year in children, And it's only 2 symptoms instead of 5. Okay. Here's our next recipe. We have 3 recipes coming up. We have bipolar 1, bipolar 2, and cyclothymic. All of these recipes, they're going to have multiple ingredients, major ingredients, right? Okay, so let's go over all of the ingredients. We already went over MDE. Let's go over manic and hypomanic. Those are the 2 things we're going to go over now, because you're going to see them come up as we go through our mood disorders. You're going to see them continue to surface, okay? So manic episode. Let's get our time frame in first. At least 1 week. It has to last 1 week. It is a mood episode, right? So you have an irritable, elevated, energetic mood. You have to have 3 or more of the following. And you see there are 7 listed. Do you need to know all 7? I would say probably not. Here's kind of the major thing you'll see on the exam. Lack of sleep. Write that down. Lack of sleep. They're also going to talk about how they're speaking rapidly. So rapid speech, lack of sleep. They're also going to talk about how they are very impulsive. And typically on the exam, they're going to say spends lots of money. Now, by now, they should have come up with another example of being very impulsive, but that's kind of what they have stuck with. Manic also can be associated with kind of danger. So when you think of manic, I want you to think of danger. They kind of put themselves into dangerous situations. And that could include inappropriate sexual activity, right? Because they're not sleeping. So they're up. And I don't know if you've ever stayed up for multiple days. I can relate to these things. But what I want you to also write down is that manic also equals psychotic features. The very essence of having a manic episode is that there are some type of psychotic features present. So you're going to write down at least 1 week. You're going to write down it's a mood episode. Elevate your mood is elevated. It's like a high almost. You're very irritable and you have increased energy. But it's not in a good way. It's not a good increased energy. It's actually very dangerous, right? It's kind of dangerous. Things that you're going to keep in mind is that you have a lack of sleep, rapid speech, and typically it gives you some type of impulsive behavior like spend lots of money. That's typically what it'll give you. But it could give you any other impulsive act. It is categorized by psychotic features. What do I mean by that? Hallucination, delusion, to the point where they must be hospitalized. So manic is characterized by psychotic features like hallucinations, delusions. Anytime you hear psychotic features, that's what we're talking about. And it requires hospitalization. That's how bad it is. So manic, a lot of times we talk about like our famous inventors and how they had mental health disorders. And sometimes we talk about a manic episode like in a good way, like they were so off, they were brilliant. Manic is not one of those things, okay? They probably were hypomanic. Hypomanic people, they are actually very functioning. They function, right? But manic is dangerous and it's not, the function is not there. So that's what I want you to write down for manic. Oh, I'm sorry, I went too far. Okay. Hypomanic. It's like a step down from manic. Same symptoms, okay? Same symptoms, but it only lasts 4 days instead of a week. Same symptoms, but the duration is shorter. There is no psychotic features present, because psychotic feature, that represents manic. So if those are present, then it's going to be manic. But hypomanic, they can function. They do not have to be hospitalized. There are no psychotic features. So that's really the difference. The duration is shorter. And my impulsive behavior may be to clean the house all night, right? It's not dangerous. It's actually could be a good thing. But the lack of sleep is like I have a friend who she can, one day we're like, yeah, I'm gonna start a business and I'm gonna write a workbook or something. Then the next day she's like, yeah, I wrote the workbook last night. What? Right? It's like, oh, might be, it wasn't 4 consecutive days, but I'm like, that sounds a little hypomanic, right? It's kind of like I won't say it's good because it's in the DSM, but it's not dangerous. Okay, so now we have our 3 ingredients. We have MDE, we have manic, and we have hypomanic. Okay, let's see what we can make with these ingredients. We can make bipolar 1. Bipolar 1 consists of manic and depression. So a manic episode followed by a major depressive episode. That's bipolar 1. And remember, we said manic is dangerous. So bipolar 1, just by definition, is more dangerous than bipolar 2. So if they ask you what the difference is, that's it. Bipolar 1, there's a manic episode present. Bipolar 2, there's a hypomanic episode and then a depressive episode. So by definition, bipolar 1 is more severe and more dangerous, if you will. They're not going to put on there that it's more dangerous, but I'm just letting you know in kind of plain terms. Okay, let's see what else we can make with these ingredients. We're going to be talking about these ingredients, okay? Cyclothymic. This is similar to PDD, but it's like the bipolar version of PDD, right? You never meet the criteria for any episodes. You never meet the criteria for major depressive, manic, or hypomanic, but you have symptoms, right? So you may be having some symptoms, but you don't meet the criteria because it doesn't last long enough, right? So it doesn't last 2 weeks, it doesn't last a week, and it doesn't last 4 days. So the duration, I'm sorry, let me take that back because the duration is actually long. You don't meet the criteria because of the symptoms, right? So let's go back and see. We know MDE, we need 5, and hypomanic and manic, we need 3. So maybe you don't have 3. Maybe you have 1. Maybe you have 2, right? That's what that means. So you don't meet the criteria in terms of severity, but you do have the duration is at least 2 years and 1 in children and adolescents. So 2 years for adults, 1 in children and adolescents. So cyclothymic is like long-term bipolar. You're having numerous periods of different symptoms. right? Numerous periods of hypomanic, but you don't meet the criteria. Numerous periods with depression, but you don't meet the criteria. But it's lasting longer, but you don't have enough symptoms to categorize it as an actual episode. Before we move on to schizophrenic, I think this was next. Yeah. Before we move on to schizophrenia, is there any questions about depressive disorders or bipolar category disorders? Any questions? I have heard that they will ask you the difference between bipolar 1 and bipolar 2 possibly. But typically in terms of diagnosing, you wouldn't diagnose a scenario with bipolar 2. It's typically is bipolar 1. But they may ask you what's the difference between the two. The difference is bipolar 1 is more severe and manic episode is in bipolar 1. Manic episode is not in bipolar 2. And that's really the difference. All right, I don't see anything in the chat. Let's keep it moving. Okay. Schizophrenia. This is another major disorder that you should know. So if you're thinking, why should I study all this stuff? It's not even going to be on there. I can roll with that. But I at least want you to know everything we've talked about so far. Everything we've talked about so far is really, really important. Schizophrenia may not be on there, but elements of schizophrenia is definitely going to be on there. You're going to have a client that may have a hallucination, a delusion. So you want to know, what does this mean? You need to know the terms of schizophrenia, even if you don't see schizophrenia on your exam exactly. You see how psychotic features keep coming up. So schizophrenia is characterized by psychotic features. Hallucinations. There are 5 different hallucinations because we have 5 senses. So there's a hallucination for each type of sense. You have auditory, visual. It's categorized by things that others do not observe. So you're the only one that observes this or is experiencing this. Seeing people or shadows. Touch. You feel like something's on you, crawling on you. I feel that a lot. Okay. Smell and then taste. Now, I don't know how you would prove that someone's tasting something that no one else tastes. That's probably a little harder thing to do. But everything else, you know, is something that everyone is, you're able to say, okay, no one else is observing that. Delusion. Delusion is a false belief. And you see, not held by others of the individual's culture. So of course, culture is going to be involved in delusion, right? But the reason why it's a delusion is because the individual cannot be dissuaded that the belief is untrue, even if there's evidence to the contrary. Now, some things, of course, we have a lot of philosophical things, a lot of belief systems. So we're not really talking about that, right? Because this, what we're talking about right here is it's going to impair you in some kind of way, right? And it's typically going to be in combination with either hallucination or disorganized speech or some type of negative symptom. So disorganized speech, I definitely had a client that had this. Although I was not a clinician, I primarily did child welfare. My client definitely did this. Disorganized speech. No logic to the conversation, just kind of words together, but they don't make any type of sense. That's what disorganized speech is. Sometimes it's also presented as a word salad, where the individuals is just speaking words that do not go together. Then you have negative symptoms. Negative symptoms could be like flat affect. We talk about that a lot. It also could be their expression, lack of expression. Those are some negative symptoms. Schizophrenia, it's going to be at least 6 months. Usually, I got this out of the DSM, usually before the age of 25, usually. So you're not really going to find schizophrenia being diagnosed in someone who's 40 or 50, right? Whereas you can diagnose depression in that age. Like, there's not really a lot of other disorders that have an age restriction. And it's not that you can't, it's just saying commonly you're going to see this before it's going to manifest before the age of 25. Something about that young adult age that triggers this. It's really very interesting. Significant impairment. We know that's typical for most disorders. 2 or more of the following symptoms. Here we go. Must have one of the following. Must have one of the following. And these have to be presented in a period of 1 month. So our duration is 6 months. But you might not have your delusion for the entire 6 months, right? You might have a combination of these things, and you're supposed to, right? 2 or more of the following. But any of these symptoms has to happen for at least a month. So you can't just have a delusion and then you're like, oh, well, actually, I don't believe that anymore. Then that doesn't count, right? It has to be at least 1 month for each of the symptoms. But altogether, you're having 2 or more symptoms for at least 6 months. Hopefully that makes sense. You must have a delusion, hallucination, or disorganized speech. Has to be one of those. So when you write schizophrenia out, you're going to write delusion, hallucination, disorganized speech. And then I also want you to understand what these terms mean as well. So those are the times where I want you to do a deep dive and figure out what these mean. You might do a YouTube and see what they mean. Schizophreniform. It's like baby schizophrenia. Meets all the criteria. So you have your hallucination, delusion, or disorganized speech, and it's combined with another symptom or a combination of those. So it has 2 or more, but it's less than 6 months. And you normally are not impaired. So it's like a baby schizophrenia, not as severe, not as long. Doesn't meet the criteria in terms of the duration. Schizoaffective. This is what I was talking about earlier. Sorry. There's so many schizo. It's schizoid, schizotypal, schizoaffective, schizophreniform. Like, there's so many schizos. So schizoaffective. And this makes sense, right? Schizo affect, right? Mood. So here's another recipe. When you have psychotic symptoms and a mood episode, you have schizoaffective. Another word that is on here is catatonia, just another term that I want you to be familiar with and know a little bit about it. You don't have to memorize everything on this slide, but I just wanted you to know what that catatonia means: a lack of movement and communication. And those that are in the field probably have a really good understanding of what that means. And if you're visual, you probably have to Google it and find an image or video of someone that is experiencing this to really figure out what this is. So schizoaffective, it lasts a minimum of 1 month, and it can manifest in any order, but it definitely has schizophrenia symptoms and a combination of either depression, manic, or a mixed episode. And mixed episode just means you're having depression and manic at the same time. But it's all concurrent, it's all happening alongside of schizophrenia symptoms. All right, delusional. Delusional disorder typically does not impact functioning, typically, unless you start to challenge the delusion. So remember, we said this is a false belief. It has to last for at least 1 month. And you never met the criteria for schizophrenia. So it's not like you're going in and out of schizophrenia and you're having a delusion. No, you have schizophrenia, right? Delusional disorder, you've never had schizophrenia. This is the only thing you're really having an issue with, is this delusion that is lasting longer than a month. And there are different types of delusions, which we're going to go over. There are a slew of them. The main one that you'll see is persecutory type. This is where the person is feeling harassed, attacked, cheated on, persecuted, or conspired against. Like someone is always out to get them. This is the most common delusion. Any questions on schizophrenia or any category of schizophrenia? Let's go ahead and take a 5-minute break. So we'll come back at, my time is 8:05. So let's take a 5-minute break. I'm gonna pause the recording. Just please remind me to restart it. All right, let's come back together. We have a few more disorders and then we are going to get started. Okay, so now we're gonna go into anxiety disorders. You may relate to some or a lot of these, right? Before we talk about anxiety, or as we talk about anxiety, what I want you to know is that in general, all of the disorders that we're about to go over, they are categorized by apprehension and physical symptoms together. So I'm anxious, and the reason I know I'm anxious about a particular event or towards a particular object is because I'm having these physical symptoms as well. So a lot of these symptoms that you'll see categorized for a panic attack is actually going to show up in pretty much all of our disorders that we're about to go over that's under anxiety. So a panic attack is categorized by 30 minutes, less than 30 minutes normally, and it's experienced 4 or more of the following. And you see all of these are kind of anxiety related symptoms, right? Shortness of breath, feeling dizzy, derealization. Derealization is another term. If you've never heard of it, go ahead and write that down. Derealization is feelings of unreality. So you feel like you're not in reality. It's kind of like you're having an outer body experience. It's kind of like that. Chest pain, trembling. So you see all of these physical symptoms, and it's typically going to be brought on by something, right? Separation anxiety disorder. What I want you to keep in mind with separation anxiety disorder, I know that we talked about separation anxiety when we talked about babies, right? We talked about object relations. That's really the entire thing about object relations, right? Is a child separating from their mother and feeling a little anxious and how they kind of process through those feelings. Separation anxiety disorder means that the child has an attachment. So if there's something in the scenario about how the child is not bonding, it's not separation anxiety disorder, right? Separation anxiety disorder says the bond is so strong that they're having issues functioning outside of their person. And this can be found in children, adolescents, or adults as well. So symptoms must be present at least 4 weeks in children. in adolescents and 6 months in adults. Developmentally inappropriate and excessive anxiety. And the anxiety is coming from being separated from the person they're attached to. It could be a parent or also could be a child in the instance of an adult. So that adult is so attached to their child, so attached to their spouse that they are having some symptoms around being separate from them. In children, it's not appropriate to diagnose this under 2. Why? Because that's normal. Separation anxiety is normal. After 2 years old, we need to figure out, kind of what's going on. It may look like the child refusing to go to daycare, always having some type of physical complaint to justify why they want to stay home. And in adults, it could be a fear that something horrible is happening. Selective mutism, also anxiety, right? But the anxiety is focused on speaking in certain situations. So I don't speak, but it's not because I have some type of developmental issue or a speech delay, but I'm not speaking in certain situations. So it's some type of apprehension. We have to figure out kind of where is that coming from? And it's normally for younger kids, right? Beginning in preschool years. Has to last a minimum of 1 month. Specific phobia. Most people have phobias, right? And most phobias begin in childhood or adolescent, and you really can have a phobia about anything. Some phobias have an actual name for it, but if you say a situation or an object and then put phobia behind it, you can make that a phobia about anything, right? It's an unwanted fear of a specific object or situation. You are concerned that the object is going to cause you some type of harm, some type of embarrassment, or some type of fear of the consequence. So claustrophobia, right? Everybody's kind of familiar with that. Fear of heights, and then arachnophobia is a fear of spiders. A lot of people have fear of dogs. So you could call that, I don't know if that one has a specific name, but dog phobia. And then we have social phobia. That's like the common term, but we know it in the DSM-5 as social anxiety disorder. Snakes, yes, a fear of snakes. Social anxiety disorder is the fear or anxiety about social situations. The individual is fearing that they will come off as clumsy, silly, or shameful, and having this behavior observed by others. Occurs in middle teens. And in children, it looks a little different. It looks like clingy, crying, withdrawing versus anxiety as we may see it. LMSW and LCSW test taking. Yes, that's a phobia too. Absolutely. Okay, so remember we talked about panic attacks. Now we're going to talk about panic disorder. A panic disorder says that you've had at least one panic attack, but it's also followed by you worrying about another attack happening or even changing your behavior to avoid another attack. So it's kind of like you had a panic attack, but panic disorder says they're reoccurring, and you are apprehensive about having another one. So if you have a panic attack and you don't have another one, you're not really worried about it, you probably don't have panic disorder. But if you're having them recurrently and you're worried about having another one, trying to avoid them, early 20s and common in women, and that's exactly when I had my first one. I was like, what is this? What's happening to me? All right. Agoraphobia. This is when someone is scared or apprehensive, anxious when a person is home alone or away from the home. So either one. I'm anxious when I'm home alone, or I'm anxious when I'm out in public. Symptoms must persist for 6 months. It's not highlighted, but it is underlined, so that's important. And you're worried that escape would be impossible. Yeah, general anxiety disorder. I'm also familiar with this one, okay? Excessive worry, but this worry is not necessarily about a particular thing. So everything else that we've talked about is kind of triggered by something, and is specific to something. This one is not specific, it's just in general, I just worry about everything. And having difficulty controlling the worry, at least 6 months, doesn't necessarily experience panic attacks. So it's not necessarily that you're just panicking all the time, but it's that you had a general worry about everything. And these are some of the symptoms of anxiety, general anxiety disorder. You have to have 3 or more. Again, in the scenario, it's not going to say, you're not going to have to see, oh, does it have 3 or more? But what you are going to want to know is there excessive worry happening? Is it for at least 6 months that it's happening, right? Do I see any of these things? Irritability, difficulty concentrating, that's what you're going to see, typically. But fatigue, sleep disruption, restlessness, all of those things, 3 or more of those. Okay, so that was our anxiety disorders. So now we're going to switch gears and we're going to go to trauma and related stressor disorders. All of the disorders that we're about to talk about identify a trauma that is triggering, right? So there's some type of event, and then this is how we are responding to that event with this disorder. With each of the disorders we're about to cover. So reactive attachment disorder, and the next one we're going to go over is disinhibited social engagement disorder. Both of these disorders have something in common. They have the same stress event, but the reaction is different. Reactive attachment is for 5 and below, like the store, 5 and below. But you have to be at least 9 months. So you can't be 1 month and experiencing reactive attachment disorder. But you can be 9 months, because 9-month-olds, they're very aware of things. Let's see what the stressor event is first, so that then we'll work backwards. The stressor event is neglect. Having multiple caregivers or not having that one person take care of them, they're being neglected. They could be in foster care, or they could be in some type of institution where there's just not a level of care and affection happening, right? So that's the stressor event. The reaction for reactive attachment is I don't want to bond with anybody. I don't want to be attached to anybody. That's pretty much the symptoms. So minimally seeks comfort. If I'm distressed, I'm not trying to cry in your shoulders, those types of things. And if you try to comfort me, I don't want it. Limited positive effect. So they're not really happy, right? They're not happy. They're withdrawn. So this disorder, you can kind of think of it as an internal disorder. So I had this stressor and I'm internalizing it. Whereas disinhibited social engagement disorder, I have the same trauma, but I'm externalizing it. So with disinhibited social engagement disorder, I cling to everything. And working in foster care, this happened to me so many times. It's sad either way, but it's definitely, I'm like, oh, as soon as the little girl saw me, she ran up to me, she gave me a hug, sat in my lap, and asked me if I could be her like sister or something. I was like, oh, like, can you take me home? I'm like, oh. So external, actively approaches and interacts with unfamiliar adults, overly familiar verbal or physical behavior, right? Hugging me, sitting on my lap. I don't know this girl. So all of those things, willing to go off with an unfamiliar adult without hesitation. So they're just super clingy, pretty much. Super clingy, super quickly. Okay, here's our next trauma disorder, PTSD. We all are pretty familiar with it. The only thing I want to point out is that it involves you experiencing it or you witnessing a traumatic event and surviving. So it's kind of like you had a life and death situation and you survived it. And so now different things are going to trigger you because of that trauma that you've experienced. The event, this is not an exhaustive list, but these are some types of events that may cause PTSD. Accidents, car, motorcycle accidents, combat, right? Our veterans, disasters, right? Hurricane Katrina, that's like something that really pops up into my mind. Sexual, it's not a man-made disaster, but the pandemic. We can definitely have PTSD from the pandemic. It wasn't a like natural disaster, but it was a really, really terrible period in our lives in many different facets, right? So also sexual abuse, any type of child abuse, rape, kidnapping. These are just some types of examples. And it's categorized by a lot of things, right? You are exposed to a serious event. Even first responders, even though they're not experiencing it, but they're witnessing it. You are having some intrusive, distressing memories, flashbacks, avoidance of stimuli, diminished interest in significant activity, so you're detaching from others, anger outbursts. So it's a lot of different symptoms all coming from that event, and it has to last more than a month, causing significant impairment. Acute stress, all of the same symptoms except for the duration. So acute is less than a month. but it has to be a minimum of 3 days. So 3 days, and it has to resolve within 4 weeks. That would be an acute stress disorder. Adjustment disorder. Again, some type of event, trauma that happened. There is an out of proportion, we keep seeing this, right? Out of proportion reaction to your event. This doesn't have to be life or death. This just is any trauma that you're experiencing. It could be that you lost a job and you're just having marked distress that's out of proportion, right? It has to occur within 3 months of the stressor, but it does not persist more than 6 months, because then after that, it probably is something else, right? ADHD. This is characterized irritability, impulsivity, right? Inattentive, hyperactivity. So we have 3 types. We have predominantly inattentive, predominantly hyperactive, and we may have a combined presentation. Symptoms must persist for 6 months. And it has to be before age 12. So again, this is another kind of child disorder. However, I know that adults are diagnosed with this as well in adulthood. ODD. You down with? That's OPP, but that's what I think of. ODD, oppositional defiant disorder, has to be present for at least 6 months. It gives you a variation of how often within those 6 months by the child's age, but it has to be at least 6 months. It is more common in males. Angry, irritability, easily annoyed, loses temper. The main thing is that this child, typically as a child, is not violent. Aggressive behavior is not normal. It's more of, I don't want to follow rules and I don't respect your authority. So I'm going to be irritable. I'm going to have temper tantrums. But it's really about authority, breaking rules, because we also know that DMDD has something to do with temper. We know with ODD, it only has to be in one setting. It may be absent in a school setting, so that's a difference. And again, that rule, breaking rules, not respecting authority is going to be your primary feature here. Conduct disorder. Now, this is your violent disorder, okay? This is your criminal, antisocial disorder, okay? It is not antisocial personality, but typically conduct disorder may lead to having antisocial. So this one is 12 months. So that's a little longer, because we really want to, before we diagnose you, we really want to make sure you got this thing, right? 12 months, long time. 3 or more. The pattern is repetitive and persistent. It is more common in males. And we're going to see behaviors like violating people's rights and animals' rights, right? Harming people or harming animals, property damage, theft, setting fires, stealing. So this is a child who is criminal in nature. The behavior is criminal in nature. I want you to think of Jeffrey Dahmer. After seeing that documentary, I was like, when he was in his childhood and he was cutting up them animals, and his father was like, oh, this is a nice hobby. No. That didn't turn out good, okay? No, that was not good, right? Yes. So when you think of antisocial, I want you to think of a sociopath. Like we say stuff like sociopath, and this is really what we mean when we say that, right? Criminal behavior. Okay, now we have obsessive compulsive disorder. I think we're all familiar with that. I just wanted you to know that obsessions is the thoughts and compulsions is the behavior. So compulsion is I'm checking the knob 30 times. Obsession is I'm just always thinking, is my door locked? Is my door locked? Is my door locked? And they're so time consuming that you're late for work. You are no longer, you're ruining your friendships, things like that. Dissociative identity disorder. This is characterized by the presence of two distinct personality states. This used to be called multiple personality disorder. I think of Split, but it was another movie or a documentary or something that was more recent than Split that had this in it. I forget what it was. Right? They have different personalities and sometimes they don't remember. So today I'm Jessica, and the next hour I am Lydia. And one doesn't remember what the other one said or did, right? Oh, Sybil. Okay, that's another good one. Factitious disorder. With this one, every time I teach this, I forget the movie, but you're gonna remind me of the movie where we had the mother who was convincing everybody and the little girl that she was sick and she was perfectly healthy. I mean, it was crazy. That was factitious disorder imposed on another, which we used to call Munchausen. But factitious disorder is different from you calling out of work and faking sick, okay? That's not factitious disorder. Factitious disorder says, I want medical attention. That's the primary, right? I want medical attention and I'm embellishing or fabricating my symptoms so that I can gain this hospital admission, move from hospital to hospital. Like that's really what the crux of it is. The other term that is not a disorder, but y'all just foul, and me too. When we call it, we like, right? Or you like, I got COVID. Right? People do that too. Oh, good, I'm out of work for 5 days and I get paid, right? That's called malingering. Malingering means that I'm getting some type of benefit, even if I'm faking an illness so that people will fund my GoFundMe. That actually is malingering. It's not factitious disorder because the intent is to get something out of it. I'm gaining some type of reward out of it. I'm either missing work or I'm getting money, I'm getting attention from people. But factitious disorder is I'm getting attention from medical professionals or the medical system, right? It's not about money. I don't want people to donate to me. I want that medical, I don't know what it is. I don't know what's behind that, but, and they're so engrossed in it, right? They're threatening to sue the people, all of that. Then it's the sexual disorders. This is what we talked about, the paraphilic disorders. And so there are 8 different types, and I included this is part of a quick study academic that has a DSM-5 like quick study. So I just screenshot it for you so you can see what the different ones are. So that's just something for you to be aware of and study. Then we have enuresis and encopresis. This is when it's developmentally not appropriate for them to be doing this, right? I know of an 11-year-old who is still wetting the bed, right? There's something going on. And actually, when you dig a little deeper, it was some sexual abuse occurring. So it's definitely not on purpose. It's definitely not, he's just a bad kid because he keeps wetting the bed. It's not, oh, we just need to stop feeding, giving him water by a certain day, by a certain time. It's because it's some type of trauma going on. So that's enuresis. At least twice a week and at least 3 consecutive months of it is enuresis. Encopresis is going to be expelling feces, and the child has to be at least 4 years old, right? Because underneath of that, anything younger than that is normal, possibly. Personality disorders, these are our favorite. So what I want you to do is I want you to study the personality disorders, all of them, and put them in a way that allows you to learn them. You've heard me talk about your learning style, so you want to be able to capture this information via your learning style, whatever that is. So I use a lot of note cards because I'm very highly visual. Don't talk to me about anything. Please send me. That's probably why I hate talking on the phone. I hate talking on the phone. Please text me or email me because I have to see it. Talking on the phone to me, I mean, if I'm just talking about stuff, but if you want me to like give you some intelligent answers or something, I need to see it for me to be able to process it. So I use a lot of note cards. So I put this stuff on note cards: paranoid, inappropriate suspicion, schizoid. Remember, it's schizo everything. Schizoid is part of schizophrenia. Schizoid and schizotypal is just 2 different parts. So the schizoid is about the range of emotion or lack thereof. Yes, Gypsy was the Munchausen, and they have a lot of it's like at least 2 movies or documentaries on the same girl. Schizotypal is the other part of schizophrenia, the peculiar or odd side of it. Antisocial is the Joker. It's not that the person doesn't like being around people, is that they are anti-society. That's really what it should be called, anti-society. They're not going with any type of rules of society. Borderline personality disorder, unstable in relationships, self-destructive. So if they talk about self-harming behaviors, that's associated with borderline. Mood, very moody, and needs boundaries. Definitely needs boundaries. And we know that DBT is our common therapeutic approach for our borderline personality disorder clients. Histrionic, drama. Okay. Narcissistic, we're all familiar with that. Avoidant says, hey, I like socializing, but I really am scared that I'm going to be rejected. And so that's why I don't socialize. It's not that I don't want to, it's just I'm scared of rejection. Dependent, and then we have obsessive personality disorder as well. And remember, with our personality disorders, this is something that's going to begin in early adulthood. So we're not going to diagnose anybody with a personality disorder that's not an adult. The other thing I want you to know is that it's different, right? It's not like the other disorders where there's like tons of criteria. It's really about a pattern of behavior. It's kind of like the bad parts of you, the bad parts of your personality that's impacting you. Okay, other terms. We have pica, I think I saw that on I definitely saw that probably on Chicago Med. I'm pretty sure it was Chicago Med or Grey's Anatomy, where it was like a big ball of hair because they were I think it was Grey's Anatomy because she was eating her hair. That was, yeah, that's like it. Magical thinking. Magical thinking says, because I did this, this is why it rained. This is why I had a great day. Because when I woke up, I put my right foot over the bed instead of my left foot, right? It's like magical, magical thinking. We have delirium. Okay. And now we're going to go into medication. And we're right good with time. We're not going to spend a whole lot of time on medication because it is just memorization. But if you have some tips on how to memorize the medications, drop them in the chat. When I was developing this curriculum, the slide curriculum, I was teaching a substance use course that talked about neurotransmitters. So if you see a lot of information about neurotransmitters, it's because I was a little geek when I was making this, and I was like, oh, this is what SSRI means? I had no idea. I just thought it was some letters. I didn't know that all of the medications are really trying to manipulate your neurotransmitters, either giving you more of a neurotransmitter or limiting the amount of that neurotransmitter to adjust your mood. So that's where mood regulation comes from, right? So when you see serotonin or SSRI, that's kind of what that is talking about. Remember that even though medication may be part of your treatment plan, it is not your responsibility to manage the medication. That is the job of the doctor or psychiatrist. So you want to make sure that you're referring them. If your client is saying that they're having issues with the medication or they stop taking a medication, you should not advise them about it. You should not say, well, you need to go back on the medication. You should not say that, right? What you should say is you might ask a little more information, like how long have you been off of it? You might ask them what their symptoms are, right? What their side effects may be. But that's about it. You may also help them create questions to ask their psychiatrist if they're feeling like they can't really talk about it or having a little apprehension of talking to their provider about it. But you're not going to get any advice. You're not even going to Google the medication and say, hey, these are the side effects. This is why you're experiencing this, right? Even though that's what we're going to do, right? But on the exam, we're not going to do that. My aunt, she is Dr. Google. She goes on Dr. Google and she looks up, not even on Google, but just on the bottle, she lists out all of the side effects. And then she lists what side effects she's having. And then she tells the doctor which medications are causing this. She's like, well, this is the medication you gave me. This is the side effect. This is why I'm having it. You need to take me off this. That's what my aunt does. And that's probably what we're going to tell our clients too. But on the exam, we're going to stay in our lane. So I think you should memorize the medications by category. It just makes sense, right? So you want to not only remember the antidepressants, but if they're a SSRI, if they're a MAO, if they're atypical, I would memorize them like that. So that's why I categorize them like that. And then sometimes you can kind of see a little bit of a pattern. So this is like especially with the knockoffs, generic brand, you see like a pattern with the ending of it. It's not a pattern with our brand names. They don't really have a pattern. But sometimes especially when you get to your benzos, it's like a little bit of a pattern. So that may help you as well. Also, sometimes I get questions about this. What if a medication has multiple uses, right? So this medication is used for antidepressant. It also is a blood pressure medication, right? So, how do I answer the questions? So this is what I'm going to say. So what you're going to do is you're going to go with what is commonly used. So these medications listed on here are commonly used for antidepressants. If they're used for other things, they may be, but these are commonly used. And you'll see at the end, SSRIs can also be used to treat, I think that says OCD. Hold on, let me move my little thing. There it is. Yes, OCD. So you see how it could have multiple uses, but what I want you to memorize is the common use. Again, you may only get one medication question. You may get 5. I don't know. It's not a lot though, but you just want to, you're trying to maximize all points at this point. That's why we're going over it. Benzos, you see, again, it's a lot of lambs and pams for our generic brands. I also want you to know the side effects. We just talked about that, but I do want you to know the side effects. It's really easy. Antidepressants sometimes impact sexual dysfunction. Anti-anxiety is very fast acting and addictive. So you typically don't want to be on an anti-anxiety medication for a long period of time, especially if they are highly addictive, depending on which kind you get, right? Here we go. Beta blocker is an anti-anxiety, but beta blocker is also used for, that sounds like something with the heart, right? So you see how there's multiple uses. And your focus is obviously going to be on the mental health side, but there are multiple uses for a medication. Antipsychotic, this is used to treat schizophrenia. You see all of the medications for that. Haldol is probably the one that, and Risperdal, Abilify, yeah, those are the main ones. And then the side effects, tardive dyskinesia. Every time that I see a commercial about tardive dyskinesia, I think about this class. We have some acronyms, some ways to kind of memorize. So go ahead, write that down. And I'll make sure I put it in your email for tomorrow as well. Then we have our bipolar disorders, lithium, it's most common, but Depakote also treats it. Psychostimulants used for ADHD. Remember that paradoxical effect we were talking about? Adderall. What? Right? Adderall is a stimulant, amphetamine, right? That's a stimulant, but it is used for ADHD because it gives that paradoxical effect. Also Strattera. And that is our last slide. We are, that was a lot, right? That was a lot. So you can go ahead and stretch. I'm just going to bring up our questions. Don't go too far. I'm just going to bring up our questions real quick. Give you a couple minutes. We are going to be using a polling site. I'm going to drop the link in the chat. The questions are going to go by super fast because the majority of them are definition based, right? So when we reveal the answer, it's not a whole lot of back and forth. It's not a whole lot of, debate necessarily because it's based upon a definition. So I am going to drop the link in the chat. What I want you to remember is that this poll does not take record of whether you get it wrong or not. So make sure that you have your phone out, you have your paper and pencil. So as you're going along, you're putting down your answer. If you're torn between two, write that down too, because that way when we discuss the answer, you can kind of relate. And then make sure you mark it wrong or right so that at the end we can see where you're at. It's very common for you to get a lot of these wrong, because if you have not started to study disorders, then you're going to get them wrong, right? Because you don't have that knowledge, you don't have the base that you need. And so my suggestion before you move to the actual homework is to study first. We are going to go over 10 questions live. I just put the poll in the chat, but you also can just do your question on the screen, put your answer in the chat if you're not using the poll, but I just ask that you wait the 45 seconds before you put it in there. So I'm gonna put 45 seconds on the clock. Is the poll, let me see if the poll's working, because you probably, yep, I got some answers. I got one answer. It's right, whoever did the answer already. All right, so I'm gonna put 45 seconds and then we're gonna discuss the answer. All right, go ahead and put your answers in on the poll or in the chat, whichever one you choose. As you are putting your answers in, let me know what category of disorder is agoraphobia, obsessive compulsive disorder, panic disorder, social phobia. Tell me what category that is. Perfect. Anxiety. So once we identify that it's anxiety that all of these things have in common, then we just have to match the medication with the disorder. So MAO, SSRI, those two, A and B, treat depression, and D, amphetamine, treats ADHD. So our answer is going to be C, benzodiazepine. It's a group of medications, so it didn't give us an exact medication, but it gave us a group of medication that commonly treats anxiety. So the answer is C, benzodiazepine. Let me know if you are still confused. They're typically pretty straightforward. Let's go to the next one. Okay, go and put your answers in. Okay, it looks like you didn't fall into the trap. You did good. Did really good. The answer is A, avoidant, because avoidant is associated with rejection. Avoidant rejection. No one, I don't think anyone picked antisocial, so you didn't fall for it because antisocial is really anti-society. It really has nothing to do about social settings or social situations, right? All right, you all are doing great. Let's go to the next one. Okay, go ahead and put your answers in. As you're finishing up with your answers, I just wanted to kind of go over our liked method. The liked method is just a way to break down questions. Last sentence first. Identify the type of question, which all of these are diagnoses. Key concepts, which are really important. Eliminate it down to 2. And then identify your distractor. So which diagnosis should the social worker consider? Really what I want you to focus on is what are your key concepts, because these are going to be all of your symptoms. Severely depressed, okay? The client went without sleep for several days, spent large amounts of money, and talked rapidly. So these are classic for bipolar disorder. Obsessive compulsive disorder, none of those really fit, even though to spend large amounts of money might feel like that's impulsive, but we're going to get rid of that. Major depressive disorder, you may have seen the severely depressed, but then we have some manic episodes, manic symptoms. So we're going to get rid of, well, I got rid of that. Cyclothymic, you could have been like, oh my goodness, well, they said it happened in a year. But actually it just says earlier in the year. It doesn't say that it lasted for a whole year. But both of these are going to be bipolar. And remember, cyclothymic does not have manic in it, right? So that's why it's not cyclothymic. All right, let's go to 4. Go ahead and put your answers in. All right, go ahead and put your answer. I think I said that already, didn't I? Yeah. Okay. What is the most appropriate diagnosis? Let's see what our key concepts are. Since we know it's a diagnosis question. We have a 52-year-old woman who reports depressive symptoms and suicidal ideations following the death of a spouse. The son says, actually, my mom is lying. My dad did not die. And after questioning, you conclude that the behaviors are driven by the desire to have medical attention and not for a reward. So that really, this last sentence was really telling. And typically with our most and best questions that ask us what is the most, what is the best, this second to last sentence is typically going to give us a little more information as to what they want us to do with all this information that they're giving us. So because it's not for reward, then it's not malingering. We can take that out. And schizophrenia would have to be, we would need a little more information about that. But because the main motivation is medical attention, we're going to go with A. Let's see how we did on the poll. See how. Yeah. Yes. It was either A or C. And also remember that malingering is not a diagnosis. Yeah, what does malingering mean again? Yeah, and so it's not a diagnosis. Malingering is when you fake sick for some type of reward. So I'm calling out of work and I'm faking sick so that I can stay home and don't go, so I don't have to go to work. Or I'm faking a illness so that people give me money or that I get some type of attention. Sometimes you see women faking pregnant, things like that, right? That's malingering. That's not really factitious disorder because the focus is not on medical attention, it's on other things that benefit them. Yes. Second gain, yep, avoiding jail, compensation of money, right. There's some type of benefit to it. It's really not about the medical aspect or the medical attention. All right, let's do 5. We rolling through. Go ahead and put your answers in. Okay, looks like we got our first 100%. Only took us till question 5. That's really good. Okay, react. I didn't look in the chat, but I think we got, yeah. Yeah, I think we're 100%. Do the happy dance. Yes. Come through, come through. Okay, so reactive attachment. I don't have to do really any explaining because everyone got it right. It's not separation anxiety because of the fact that the 4-year-old is not bonding. So there is no attachment. So remember, separation anxiety, there is a strong attachment, right? And that's why they're having an issue. So perfect. Let's go to the next one. Okay, go ahead and put your answers in. All right, let's see how we did. Okay, I like it. I like it, I like it, I like it. Looking good. Okay. The answer is D as in dog, DMDD, disruptive mood dysregulation disorder. I know that ODD has irritability and tantrums, but DMDD is going to be featured or recognized by the grossly out of proportion tantrums. And the outbursts are happening at school and at home. And we know with ODD, it does not have to be in both settings. So those are very closely kind of there. But with ODD, we would also see something about not following rules, disrespecting authority, or having issues with authority figures. So they're going to put that in there for ODD. And so because they didn't put that part in there, then we know that that is going to be DMDD. Okay, let's go to 7. We have 10 total, so 7, 8, 9, 10. We got 4 left. Okay, go ahead and put your answers in. Okay, let's see how everyone did. Okay, I like what I see on the poll. Okay, I think we got it. Answer is B, separation anxiety. Not wanting to go to school, not wanting to be around a familiar babysitter, something's going on, some type of separation anxiety. And so the answer is B. Great. This is good. Just for if, well, assuming that everyone studied before they took the class, this is excellent. All right, let's do number 8. All right, go ahead and put your answers in if you haven't already. All right, the answer is schizophrenia. We were almost at 100%. Haloperidol is the generic brand for Haldol, kind of similar, right, in name. And so that's for schizophrenia. It's pretty cut and dry over here. It's real. These questions are real cut and dry. Okay, let's do number 9. Okay, go ahead and put your answers in. We were a little all over the place with this one, but the answer is Stratera because the question is describing ADHD, inattentive, not trying to do homework, easily distracted, right? So we had to diagnose the child first, and then we had to say, okay, which one goes with ADHD? So A treats anxiety and B treats bipolar. So C treats ADHD. So that's why the answer is C. All right, let's do our last question. And this question is a weird question, so it won't take you very long to answer. All right, 45 seconds. All right, go ahead and put your answers in. Okay, the answer is crazy. First of all, this is a not question, so you had to reverse psychology it, right? You had to eliminate what is right versus what is wrong. So the answer is B. The age of onset for bipolar is actually 18 years and not 40. But everything else is right. An individual who's related is more at a stronger risk of having the disorder. Bipolar disorders are more common in high income communities, which was shocking to me. Females with bipolar disorder are more likely to have depressive symptoms. Do you know what bipolar disorder has to do with high income communities? Not really. But it's like, I guess the one disorder where it doesn't impact low income communities, I guess. I don't know. I was like, oh, really? High income? They just, maybe it's a lot of more money, more problems. I don't know. Okay, so tell me how you did. I'm also going to show you where your homework questions are. So this is called questions, diagnosis and medication. And when you go to page 22, that starts your homework questions. You have 15 of them. And so again, I want you to study first. I want you to listen back to the video. I also have a lot of good information. I want you to go ahead and listen to the DSM-5 TR video, kind of review the information, go over the disorders that you are weak in, that you really have a hard time grasping. Go ahead and try to memorize some of the medications, as many as you can. But it's okay. It's okay if you did terrible tonight, because tonight and probably community next week too is like terrible. It's like a terrible thing. So our next class, let me make sure I told you the right thing, because I don't think we have class next week. Let's see. Do we have class next week? No, we don't. So we have class on the 15th. June 15th is our next class, macro practice. You are so welcome. All correct. Somebody know they disorders. Okay. Yes, I love it. So I'm gonna let me take you off of mute. If anybody wants to say anything, we actually ended class before the time. Oh my gosh, we did really good tonight. Hold on. What I want you to do this week, I want you to study. We're not gonna see each other until the 15th. So I want you to make sure that you are getting at least 6 hours of study time in a week. Okay. Tonight we did 2. So if you want to count that, you can. But I want you to get 6 hours in a week. So by the time we see each other again, you should have gotten in 12 hours of study time. If you're able to, next week at 7 o'clock Eastern Standard Time, I want you to study your material. And your what I want you to do is study. I really want you to study diagnosis and medication for a week. Then your second week, I want you to go back to the previous material and see what you need to work on. Can anybody let me know what area they need to go back and study? Like they need to brush up on it. Have a great weekend, Tangi. Anybody have a weak area that's like, oh my gosh, I need more time in this? Assessment and planning. Yes. And probably those therapeutic approaches. If you didn't, those therapeutic approaches, they go, yeah. Our first week, yeah, I knew somebody was going to say human behavior, because that is a doozy. Yes. Yep, go ahead and study your therapeutic approaches. This is a catch up. The reason I put in a little break is because I want you to catch up on some stuff. I want you to digest all this information. It's a lot of information. Yep, human behavior. I know. It's so much to human behavior. It really is. It's the bane of everybody's existence. I hated it. I hated it. Okay, 10 out of 10. Yes. Come on. And homework. Yes. Yes. Come on. Get that 15 out of 15 for the homework. Yes. That's good because that clinical stuff is hard. It is definitely hard. All right. Well, I will see you all on the 15th. No class next week. I'm gonna try to send out a reminder that we don't have class next week. We have it on the 15th. I want you to get in 12 hours. Okay, don't shortcut me. I need 12 hours. I need, well, do you need to do 6 hours on diagnosis and medication? If you need 6 hours on diagnosis and medication, do your week on that. But if you really need it in another area and you got 10 out of 10 or you got 9 out of 10, this area might not be where you need to focus. You might need to focus a little more on your weaker areas, making sure. This is our 4th class. So make sure that you're going over the videos that we've already done. If you've been with us for the entire time, make sure you're going over your videos. I'm going to send you out the recording tomorrow by 9 o'clock. And it was such a pleasure seeing and hearing from all of you tonight. I hope you have a great night and a great next 2 weeks. Please email me if you have any questions, if anything comes up, any homework that you had questions about, any questions that you're like, I don't understand, please email me, send me a screenshot of whatever question you're referencing. So I'm visual so I can see it. And I will make sure that you understand, where to go, how to fix it. All right, everyone, have a great weekend. Thank you.